We are here today with Dr. Bayers, orthopaedic knee surgeon here at Hyperlife Medical Center. He's going to be answering some questions for us regarding meniscus surgery of the knee.
Hi, Lisa. Thanks for the invitation. Yeah,
Cool.
Looking forward to this.
Awesome. So tell us a bit about the meniscus and the function of the meniscus in the knee.
Okay, so in the knee, we've obviously got different structures within the knee, and each and every one has its own function. So more specifically, if you're asking about the meniscus, often referred to as the soft cartilage or meniscus, it just depends which term you want to use. I find most patients prefer the term soft cartilage because it's easier to grasp. But essentially what the meniscus is what we can see in this blue structure here. You've got two of them. You have one on the medial side, or the inside part of your knee, and you have the other one, which is the lateral meniscus, or the one on the outside part of your knee. The main function of the meniscus is essentially to provide cushioning between the two bones. And in this way it preserves joint health, so that it prevents wear and tear of the articular cartilage, which is the hard cartilage in the knee. And in that way you prevent long-term wear and tear, and if this happens, unfortunately that's when people end up with knee replacements.
Alright. So if they have a meniscus tear and it's untreated, that can lead to a knee replacement later on in their lives?
Yes.
Okay.
So it's well documented in the literature. If you have a torn meniscus and you don't treat it, the problem with the meniscus tear is that it has no blood supply.
Okay.
So anything that doesn't have a blood supply lacks nutrients and oxygen to heal itself.
Okay.
If it doesn't heal, it will cause damage to the hard cartilage.
If you have a meniscus tear, is it always an operable thing? Should you always operate on it, or is there other ways to treat it?
So there's really different types of tears that you get, and it just depends on the state of the rest of the knee health. If you have a healthy knee, in other words, you've got no articular cartilage damage, and you do have a meniscus tear, the only real treatment for that is surgical, unfortunately. I get a lot of patients who ask the same thing. They often leave it for a long period of time. So it's not uncommon that I'll see patients months after sustaining the injury that they'll see me for the exact same reason. The knee just simply doesn't get better.
Yes.
And once again, it just goes back to the anatomy that unfortunately doesn't have a blood supply.
Right. Why don't you tell us a bit about what you do in the surgery, in the scope? So when you fix a meniscus, there's two ways, right, that you can do it. You can either stitch it or you can cut it out. But tell us about the actual procedure. Is it a major surgery? Is it minor? Like, I think a lot of people are scared to have knee surgery. So just tell us a bit about what you actually do.
Okay, so you asked a really long question there, so
sorry.
it might be a long answer. So it's not as simple as a yes, no. So you brought up a few scenarios. So what the surgery involves essentially is a knee arthroscopy, which simply means a scope in the knee. So it usually involves 3 little portals. So we make sort of cuts that are about 1 centimeter at most on each side of the joint, and one above. One is simply to fill up the knee with water so I can see what I'm doing. The other is so that I can place a camera in the knee, and the third portal is so that I can use an instrument to do what I have to do. So you brought up, is it major surgery or not? Well, you're going to fall into 2 different categories of patients. Essentially, it's not big surgery like a knee replacement. However, there are 2 scenarios. So the first scenario is what you spoke about, where you do meniscectomies, or cutting out of the torn meniscus. That surgery is quite straightforward. It's in and out. It's a 20-minute procedure. It's a day case surgery. There's no restriction on weight bearing, range of motion, or activity afterwards, other than related to pain. Now, the other scenario is if you need a meniscule repair. So you're generally your younger patient, a fresh tear, and the tear that's able to be repaired is obviously is a little bit more technical. It's not longer, but it still is a day case surgery, but the restrictions afterwards are different. So your patient then would be restricted to non-weight bearing for 6 weeks, on crutches unfortunately, and then afterwards we'll only start allowing them to start partial weight bearing. The recovery is much longer, so from about 3 months onwards, that's when they'll return to activity. So somebody might ask, well, what's the difference between the 2? So the real difference, so we know the short term, that's what the prognosis is. So we have to talk about long term as well. So the advantages of the repair, however, is that you will have longevity of that knee. So in other words, you're repairing the meniscus to restore its function, and in that way we're trying to restore the normal kinematics of the knee, or the knee protection, so we don't land up with osteoarthritis in the future.
Alright, so it's better to have the repair done, but it does take a little bit longer initially to heal.
Correct.
Okay.
Tell all my patients, short-term sacrifice, long-term benefit.
Cool. So in your opinion, because I know there's a lot of controversy around it, do you think it's necessary for come for rehab to do physio and bio, or not really?
Yeah, so I think there's absolute great benefit in it. My story that I tell all patients is if you take a marathon runner who's used to running 42 Ks or so, it's used as an analogy, of course. And if they are injured and you ask them to return from their injury and run a 42-kilometer run straight away, they're going to really struggle and not enjoy life. So it's the same idea when it comes to the rehab. You are going to have deficits. You can be injury prone, so that's why you have to make sure that your dynamic stability and your recovery is at full before you return to full activity.
Can you just very quickly show us how you will test for a meniscus?
Sure.
And then if you do find or you query that there's a meniscus tear, what is the procedure that you follow after that?
Okay, so we'll demonstrate the meniscus tests in a second.
Okay.
For me personally, I'm quite an aggressive investigator, so I will send MRI scans or send patients for MRI scans for confirmation of the diagnosis.
Okay.
In all orthopedic terms, everything is look, feel, move. So the first thing that we look at, is there any obvious swelling? So the swelling of the knee is definitely one of the signs that you have a meniscal tear.
Okay.
So the way that you can do that is that you all the normal tests, patella tap test, I prefer to call it the patella ballot test. And the other way to look for stiffness is you ask the patient simply bend that knee up as far as you can go, and you ask them to place it down and keep it there. Please bend the other knee as far as you can go. Okay. Generally, if we don't have bend that's equal, that's simple hydraulics. That just means that you've got swelling in that knee. Okay. You're going to look specifically at the meniscus itself. The vast majority of the time, people get medial meniscus tears, but obviously you do get lateral tears too, but that's less common. So the real test for that is really just to feel the joint line. Always start from the front, and you move your finger slowly backwards along the joint line, and often in this medial side or the posterior medial aspect, that's where you get pain. The other test is the Mcmurray's test. There's many ways to do it, but I'll demonstrate how I do it myself. Have the knee in full flexion as far as we can go. Now we know that the femoral condyles are engaging that meniscus, and you simply just turn the foot into internal or external rotation. If you turn the foot into external rotation, you're testing the medial meniscus. If you're testing the lateral meniscus, you're doing internal rotation. Okay. There is another way to do it. Some people prefer it this way. Ask the patient to lie prone. Okay. This is called the Apley's ground test. You simply bend the knee to 90 degrees. You apply pressure to the top of the foot, so you're pressing downward pressure. I usually like to use my armpit. And then you just simply grab the knee and you can twist it internally and externally. And then you can ask the patient if they're experiencing any pain.
What type of patient comes to see you with this injury, and how do they present?
So the group of patients that see me is really two large groups. So one is the group that I call the spontaneous onset. So kind of the patient that wakes up in the morning one day, kind of feels a niggle in the knee, and they kind of ignore it and they don't really know what's going on. They usually present to their GPs, they'll present to physios, they'll see guys like yourself, and then they'll eventually end up in my office.
Okay.
So these are the typical group, and it's the most common group that will end up coming to see me.
Okay.
The second type of patient that I'll see is a patient that's usually a sports player who can tell you a specific event that happened. So they'll tell you that they were running or they were doing some sort of twisting, turning activity. They felt a click in the knee. Didn't think too much of it on the day, but they seem to develop swelling over the next 24 to 48 hours. When I question them further on the surgery when they present to me, whether it's the group that presents as a spontaneous onset or whether it's the group that comes with a specific event that happened, there always is a common theme. That common theme is swelling of the knee. That's usually associated with stiffness. There's usually a new click in that knee, and that click is usually painful or audible.
Okay.
A lot of patients do complain about blocking in the knee.
Yes.
So, but what I mean by that is that they find a mechanical block in their knee. So usually what happens when the meniscus has a flap that goes into the middle of the joint and they're unable to fully extend the knee.
Yes.
They have to do a special maneuver and they feel something click back and then they get freedom of their knee again.
Okay.
So those are the main things that I go through with my patients, and that's what they complain of.
Awesome. Thank you so much.
Absolute pleasure.